Welcome, ladies and gentlemen. It's a pleasure to see you. My name is Richard Horton from the Lancet. The final session, you made it. I was in an elevator last night with a colleague at this conference, and I asked her how she thought it was going. She was from a country where women and children are presently being bombed, burned, and crushed with impunity, while the international community stands by watching and wringing its hands. And she expressed how difficult it was to be here in Berlin talking about health when she and her family were simply struggling to survive. According to the Geneva Academy of International Humanitarian Law and Human Rights, there are 45 armed conflicts in the Middle East and North Africa, 35 armed conflicts in sub-Saharan Africa, 21 in Asia, 7 in Europe, and 6 in Latin America. The highest number of armed conflicts for the past 80 years. So, as we discuss the truly extraordinary opportunity, and it is a truly extraordinary opportunity that this Lancet Commission presents, let's please frame that optimism along two axes. One, an axis of unprecedented conflict, and a second axis, a spiraling climate emergency that not only seems to have become normalized as just another challenge in global health, and maybe, some say, not the worst, but also has motivated a fierce anti-science, anti-net zero political reaction, one that in some countries is achieving significant traction. But what an opportunity this Commission offers us. That with formidable leadership and judicious investment, premature mortality could be halved by mid-century, a goal the Commission calls 50 by 50. I'm not going to spoil the surprise by revealing more about the Commission. That you will hear about shortly. But I do want to thank the team, Dean, Larry, Angela, Gavin, all of the commissioners and all those who supported the Commission, because you have done what we commonly don't do well in global health. We rely on the brute force of numbers to make our case. But you have weaved these numbers into stories that capture imaginations and inspire actions. You did it before in 2013 with Global Health 2035, a world converging within a generation. And that first chapter in this Commission's journey argued that a grand convergence in health was achievable. The end, at a minimum, of preventable maternal and child mortality, laying the foundations for universal health coverage. 2013 was the high point of MDG euphoria, peak hope, so to speak. A strange time to recall now. Unparalleled political commitments from presidents and prime ministers, unparalleled investments, a kind of intoxication with the possibility of a truly different world, one united by values of equity and liberty. Every woman, every child, the Global Fund, Gavi, new ideas, new leadership, new institutions, not a brave new world, a development dystopia, but a world where every life was respected, every life could be protected, and where every person had the right to reach for their own desired future. And then, after 2015, it all stalled. Why? Each one of us will likely have our own explanation. In the Western world, a wave of political populism, Trump, Brexit, Le Pen, Maloney, AfD, a wave that continues to roll on to this day. Or a pandemic that deflected us, punished us for our past failures, and punctured our hubris, the lessons from which we continue to refuse to learn. A distasteful antipathy for our displaced neighbours, whom we label as migrants, that has normalised racism in the public sphere. And war. It's quite extraordinary to think that in 2011, some of us, maybe some of you, certainly me, stood in a hall in Moscow watching Margaret Chan tease Vladimir Putin for being late at a meeting preparing for the political declaration on non-communicable diseases. I remember leaving Moscow optimistic about the part that Russia could play in a more inclusive global health. What a fool I was. My point is simply this, that the conditions today are not as politically propitious as they were in 2013 when Global Health 2035 was published, except that we have one great advantage today over 2013, an advantage that will be decisive for our success. Because I sense a strengthening of resistance among us, a refusal to accept a new status quo of human brutalization, bigotry and prejudice, and planetary destruction. After almost a decade of missteps, there is a renewed engagement and commitment to a more radical turn in global health, one that has multiple origins. A vigorous climate protest community, a diverse and energetic environment movement, mobilization around the quest for gender and racial equality, a renewed anti-war movement, and a progressive reaction to the populist poison of contemporary politics. These strands of modern global health activism are each a cause for optimism that we can resist by replacing nationalism with a sensitivity for our shared global identity, fossil fuels with energy derived from renewable sources, the abuse of nature with conservation and restoration, replacing weapons with words and dialogue, and discrimination with deep affection and attachment. To succeed in realizing the vision of Global Health 2050 that you are about to hear, we must bind these separate strands of activism together into a single movement and manifesto for urgent action. And this commission offers the means and the motivation to do so. So let us begin. And it is my great pleasure to introduce Dr. Ariane Hildebrandt, Director General of Germany's Federal Ministry for Economic Cooperation and Development, who is going to speak about the relevance of this commission to the German development landscape. Please welcome Dr. Hildebrandt.
Thank you, Dr. Horton, for your impressive introduction and for your powerful words and for your framing of this session in the world we live in. Honorable speakers, ladies and gentlemen, dear guests, let me extend a warm welcome to you to this last session of this year's World Health Summit. Following an increased focus on health, during the COVID-19 pandemic, investments in health are now declining. They are declining while, at the same time, people are being pushed into poverty in many parts of the world because they have to pay for their health costs out of their own pockets. According to WHO, 4.5 billion people lack access to health services, and more than 2 billion face financial hardship when paying for services they need. But despite these challenges, we have also heard of promising opportunities. Like, for example, one example that I found interesting is how our public investments in product development partnerships and health impact investment funds are effectively leveraging private capital, driving innovation in medical technologies, and saving thousands of lives. This underscores that investing in health is crucial and it is strategic. It reaffirms Germany's commitment to making health a top priority of sustainable development. I am therefore honored to open this WHS keynote session of the Lancet Commission on Investing in Health. I'm confident it will leave each of us with valuable insights. I also hope that it will inspire action. Some of the brightest minds in global health have come together to compile the report being launched today, Global Health 2050, the path to halving premature death by mid-century. The report will show where we stand today and how we can make real progress in global health in the future. I encourage all of you to consider the report's recommendations in your organizations to sharpen health investments at both national and international levels. I'm therefore pleased that Germany is supporting the Lancet Commission in translating the findings into local context, for example in Nigeria and possibly in Nepal. Both countries are considering to establish national commissions. We firmly believe that a world where all people have access to health services according to their needs is not just an ideal. It can be achieved with joint efforts, shared responsibility, and impactful investments. I would like to take the opportunity to express my appreciation to the editors, commissioners, experts, and advisors involved in putting this report together. As you might know, Germany is committed to a feminist development policy, and thus I am excited to now hear from a panel of women leaders about their vision for the future of health. Thank you very much for your attention.
Thank you very much indeed. Now, please welcome Professor Angela Chang, who is from the Danish Center for Health Economics. And Angela is going to present to you the key recommendations from the Commission. Please welcome Angela.
Good afternoon. I've noticed in global health that people like saying that they're optimists. So there's the impatient optimist. I've heard cautious optimist, evidence-based optimist, and so on. So I know it's not popular when I say that I am a pessimist. I am a big pessimist, and it drives my husband crazy. However, a year ago, I started working with the Lancet Commission on Investing in Health, and I've found myself in the very unfamiliar and uncomfortable situation in which I have been convinced that the future of global health is an optimistic one. So I'm here and very happy to share the 7 key messages that converted me into a global health optimist. You've heard a bit from Richard about the background, and I'll provide a bit more context. This commission is led by 2 senior economists. So our perspectives that we take may be different from commissions that are led by, for example, epidemiologists or clinicians. The report is a product of multiple discussions and debates among 50 commissioners coming from different geographies, generations, and gender, as well as 22 senior advisors. Our analysis is applicable to all countries, irrespective of income or region. It is not, however, a prescription for countries, but rather a starting point for local deliberation. We are not experts in everything, and so we have carefully chosen what to say and also carefully chosen what not to say, as you will see. And by no means this is a perfect report. And we are eager to have discussions and debates, for example, as you will hear today on the panel. And I'll start with a kind of a broader background in which we're facing. And you heard Richard talk about the different headwinds that we're facing. Few of these headwinds have immediate responses and interventions available. In comparison, in health, we have a better grasp of the issues in global health. We have the knowledge, experience, and good track record on improving population health. Doubling down on past health investments, focusing resources on a narrow set of conditions, scaling up financing, and developing new technologies can continue to have an enormous payoff despite the headwinds. Our first message is that by 2050, countries that choose to do so can reduce the probability of premature death, which is the probability of dying before age 70, by 50% from the 2019 pre-pandemic level. We call this goal 50 by 50. We have an interim milestone, which is called 30 by 35, 30% reduction by 2035. This graph shows the probability of premature death over time by world regions. In 2019, which is on the far right, you see that the probability of premature death was 31% globally, ranging from 52% in sub-Saharan Africa to 15% in the North Atlantic, which is made up of Western Europe and Canada. And this is the best performing region. If 50 by 50 is achieved, then in 2050, the world would be at the level similar to the North Atlantic right now. Our analysis showed that 50 by 50 is feasible based on historical experience and continued scientific advances. Since 1970, 37 countries have halved their probability of premature death in similar time length or less, including 7 of the most populous countries, coming from different incomes and mortality levels. Furthermore, there are more candidate medicines, vaccines, and diagnostics for global health conditions in the R&D pipeline than ever before, as Bill Gates mentioned yesterday. Our research suggests that we will have around 450 new products before 2050. Our second message is that sharp reductions in mortality and morbidity can be achieved by focusing on 15 priority conditions. We in global health, as with most human beings, and like dogs, have a tendency to get distracted by the next new shiny thing. Our analysis showed that of the 17,000 or so unique diagnostic ICD codes, only a tiny fraction account for the largest proportion of the life expectancy gap between the best performing region, which is the North Atlantic, and other regions. We call these the 15 priority conditions as listed here, including 8 infectious and maternal conditions and 7 NCDs and injuries. This figure shows the gap in life expectancy between the North Atlantic and other regions. For example, there's a 22-year gap in life expectancy between sub-Saharan Africa and North Atlantic, as you see in the top bar. Close to 80% of this gap can be explained by these 15 priority conditions, and over half of the difference can be explained by the 8 infectious and maternal health conditions. And this is similar for other regions as well. Close to 80% of the gap can be explained by these 15 conditions. Our message, therefore, is for countries to stay focused on these 15 priority conditions. In countries that have high probability of premature death, the 8 infectious and maternal conditions are key priorities. In all countries, the NCDs and injuries, these 7 of them, are key to achieving 50 by 50. Our third message is that the universal health coverage and the health system strengthening agendas need a reset, and we propose a modular approach in priority setting. The 2023 WHO UHC report stated that little progress has been made in service coverage and reduction in catastrophic health expenditure since 2015, suggesting that the UHC agenda has not been driving progress as much as expected. So we call for a reset. We recommend that governments maintain their focus on public financing of a core set of interventions that are fully prepaid and available to everyone, starting with the highest value for money. An initial tight focus on the priority conditions can then be expanded over time towards a more comprehensive UHC. We introduced 19 modules with different interventions that address the 15 priority conditions and improvements in quality of life. We propose a new tool called the Modular Cost Effectiveness Analysis, which adapts to local processes, health system configuration, and financing arrangements. It has 2 stages, as shown here. First, to identify modules that are appropriate to the local context and allocate budgets across the modules. And then in step 2, optimize the intervention mix within each module. The fourth message is that countries should publicly finance a short list of key medicines and commodities for 15 priority conditions. Inadequate access to essential medicines and high out-of-pocket costs are major threats to 50 by 50. We learned from the Global Fund's experience on how a national government subsidy for priority commodities can steer resources towards priority interventions and reduce out-of-pocket payments. We call this approach the Arrow mechanism, named after the late Kenneth Arrow, the Nobel Prize-winning economist and the author of the first Commission on Investing in Health, and who developed the mechanism for malaria drugs in the late 2000s. The Arrow mechanism involves 4 key components, which are to redirect the general budget transfers to Ministry of Health, to line item budgets transfers for specific priority drugs, centralized pooled procurement by government or potentially internationally, procurement of large volumes to ensure availability of drugs, and the use and strengthening of existing supply chains, both public and private. Our fifth message is that tobacco is the new tobacco. You often hear about other risk factors. For example, sugar is the new tobacco, or sitting is the new tobacco. We argue that tobacco is still the new tobacco. Just a few weeks ago, smoking remains the biggest avoidable cause of death in many populations worldwide. And just a few weeks ago, the Task Force on Fiscal Health Policy, co-chaired by Larry Summers, said, raising taxes on tobacco can do more to reduce premature mortality than any other single health policy. Our sixth message is that there is a high risk of another pandemic of a COVID-like magnitude. We estimated about 23 million excess COVID deaths during the pandemic. One of our background papers estimated a 23% chance that in the next 10 years, there will be another pandemic that is of similar magnitude as the COVID pandemic. To put it another way, in most years, there will be 0 pandemic deaths, and in some years, there will be millions of pandemic deaths. On average, there will be 2.5 million deaths per year due to pandemics. To put this number in context, currently, the combination of deaths due to AIDS, malaria, and TB are about 2.5 million deaths per year. And this number is much higher than the number of annual climate change deaths projected from even very pessimistic scenarios in the coming decades. All nations need to get ready, but many are not. There was a huge variation across country performances during the COVID pandemic, especially before the vaccine rollout, suggesting that lessons can be learned from successful countries about public health basics. So the first 6 messages were addressed towards all countries. The 7th and the final message is for the development assistance for health community. DAH is critical in achieving 50 by 50, and it should focus on 2 broad purposes. The first is the direct financial and technical support to the countries with the least resources. And the second is the financing of global public goods for health, as listed here. Successes such as the malaria vaccines and the more effective TB vaccines exemplify the enormous contribution of the DAH. For both of these purposes, focusing efforts on the 15 priority conditions would be best contributed to 50 by 50. I encourage you to read the full report. Many of you have the hard copies in front of you. And I hope some of you, especially the fellow pessimists among you, can be like me, converted into a global health optimist. Thank you very much.
Thank you, Angela. Fantastic presentation. You see how data weaved into a story with 7 paragraphs that you can remember. Our next speaker is Professor Seth Berkley. Seth is the former executive director of Gavi, the Vaccine Alliance, and he tells me now he has 11 jobs, and Seth is going to give you a historical perspective on over a decade of work from the Global Health 2035 to 2050 team. Seth.
Thank you, Richard, and Angela, thank you for doing such a great job summarizing, which, as Richard has said, is really an important report. This is actually not one report. It's a body of work, as Richard talked about. And I have the honor, along with Dean Larry Summers, Helen Saxenian, and myself, were the 4 people who were involved with writing all of these reports that I'll go through. And so I was asked to go back a little bit and talk a little bit about what we learned from some of these things, both positive and negative, and how it connects to where we are today. So with no further ado, I'm going to start with the World Development Report in 1993. Now, this was an incredibly important report, revolutionary, one might say. And really, it made the point, coming from the economic community, from the World Bank, saying investing in health was not just a cost to society, but was an investment that was justified on pure economic grounds, and that it contribute to economic growth. Prior to this, people were like, this is a cost. It's something, if you get richer, you can afford health, but this really changed the thinking of it. Now, of course, it wasn't health alone. We needed an enabling environment to improve health, and that included other sectors, nutrition, education, particularly of girls, dealing with poverty. But together, these were behind what was necessary to make these improvements. We talked at that point about the need to improve government spending and to move from tertiary to primary health care as the primary part of the spend to reach the population, to deal with treatment, going to prevention as a better way to move forward, and brought in, which wasn't used that much, the concept in health of cost effectiveness of interventions and those type of analyses that Richard talked about. We put together the concept, which, as you see in this last report is there, of having essential packages that would meet most of the disease needs of the population. Not all of them, but again, if you had limited resources, how to use those best. One of the concepts in this report was the issue of government funding essential services and then having diversity and competition in the other services. Perhaps this was a little stronger than it should be in retrospect, and there was some discussion about user fees for the other activities, et cetera, but we'll come back to that in a second. Important for all the pieces of work was this critical issue of investing in science and research and development, and particularly product development, and ones that would make a difference, so-called global public goods, and that this is a responsibility of the global community given the way they work. A set of pieces of work were done for this that really were quite important in how one thinks about quantification of diseases. The global burden of disease was born out of this report, and that was not just looking at mortality, but how do we combine mortality and disability, and also begin to look at things like risk factors for disease, and then ranking those and building a body of work that the Lancet has been very involved with over the years in terms of quantifying the effects and being able to understand what's happening with that. Now, I would make the argument that one of the most important things that came out of this report is, I think all of the authors probably read the report 2 or 3 times, but so did one person, Bill Gates. And he said afterwards that he read this report, and coming out of every page, it screamed the inequalities that exist in the world, and the fact that he learned that there were 11 million children dying unnecessarily is what led he and Melinda to move their foundation into the area of health. So I think this is obviously important, and I would argue that along with other changes, led to the golden age that Richard already talked about, large amounts of finance moving in, new people coming in, launch of the new agencies such as Gavi, the Global Fund, the product development partnerships, and really all of these can be traced back to the importance of this report. Now, as you heard, there was another report which looked at global health in 2035. You've heard a little bit about that. The first part of that report from the commissioners and authors were to look back at the WDR 93. And there were a couple of limitations that they brought out. One was they looked at the instrumental, not intrinsic value of health. And what does that mean? They said, well, you know, if you're sick, you're not productive, you're not, you know, moving the economy forward. But the truth is, health has intrinsic value. You will pay money to stay healthy. The second thing was it didn't do much on financial protection, and that is a critical point that obviously many people are put into poverty because of this. So that was looking back. In terms of looking forward, it really was a new agenda on how you work, particularly with the world's poorest population. So the first message on this was again about the value of health. In this case, the intrinsic reduction was around 11%, but if you add the intrinsic value, it went to 24% of the value of health in terms of what it's doing for the economy and economic growth. The grand conversion is possible. Richard's already talked about this, and that would have prevented 10 million deaths by 2035. It also talked about the importance of fiscal policies, which are really powerful tools for non-communicable disease controls, and that those need to be used more. And that's a more complicated agenda, which I'll come back to. And then also that you have best buys, not just in infectious diseases, but also in NCDs, mostly preventive ones, that can be rolled out in poor countries, and a lot of discussion on what those were like. It came up with a new concept, which I personally love, which is the concept of progressive universalism. So, I mean, who could be against universal health care, although maybe my country would be. But in general, I think we all understand the importance of the movement for that. But what progressive universalism talks about is if you're very poor, start with the things that are most cost effective, that can make the most difference, and then when you cover those, move to the next and move to the next, and as you get richer, move to more, so that you get the maximum effect for the population. And this is really the best pathway to universal health coverage and financial protection. And then finally, again, a strong call on international collective action for preparing for pandemics in AMR. And this is obviously well before COVID, the importance the world wasn't ready for that, and a continued call on investments in product development. Then there was another commission that occurred 5 years later. This was connected to Alma Ata conference, which was the 40-year reflection of that. And this was 5 years later, and it was 25 years after the original WDR 93. And at this point, we had begun to see the economic headwinds and the donor stagnation that was existing. But the commissioners at that point said the conversion targets for the under 5 mortality rate and HIV were still possible from the previous reports. The convergence itself was possible. Two things it called out were tuberculosis and maternal mortality as being way off track in terms of what needed to be done. And one of the issues was, how do we get better tools for tuberculosis control? And that was an important intervention that actually is now happening. In terms of prevention for pandemics, this continued to be critical. Another call, especially on influenza, and I think that's an important point because, of course, at the end of the day, we still need to be thinking about influenza going forward, and are we prepared or not? Support through non-communicable diseases, through best practice guidelines and collective drug purchases. You heard about the ARROW mechanism, but this was an important part of this report. Now looking at going beyond the measurement tools that were looked at earlier, but how do we create tools to measure the quality of health systems? And this is really an important area that we still haven't fully cracked. And measurement is critical to understand, are our interventions working? And so if we could do a better job and have a better way to measure that, that would be important. And then a call for the fact that WHO was underfinanced and that we needed to strengthen their legal capacity to deal with tobacco, AMR, and other harmful substances. And now we come to this report. Angela's done a fabulous job. I'm not going to try to repeat what she's done, but I thought I might make a few personal reflections on that. So first of all, The WGR 93 is still the only World Bank World Development Report on health. I think in a sense that's a sad thing because this report was incredibly influential and is one of the most read of all the World Development Reports. But these commissions have taken that place, and what they've been useful to do is upgrade health policy broadly with a strong data-driven economic lens. And the important thing is that each one of these reports, including this report, say the case is better than ever for investing in health. And we need to keep talking about that, particularly at a time when the headwinds are so strong. As you probably know, I'm an infectious disease epidemiologist. The progress in communicable diseases have been enormous, but of course not in all populations in all regions. And so there still is an unfinished agenda there that has to be dealt with. And particularly that's on the pandemics. You heard about the episodic burden that would happen if you were to calculate it and push it out. And I think that's an important part of this report, is a different way to think about that. Obviously, we need to learn the lessons not just from COVID, but from Mpox and from Ebola Sudan and many other outbreaks that have occurred. And we need to avoid this panic neglect cycle, which unfortunately I don't think we're doing a very good job of. In the report are many other things. So the report is 54 pages. It's comprehensive. It's long. Richard had to say enough. He gave us even a little extra space in doing that. But I want to call everybody's attention to the fact that there are, in the appendix, a whole set of other boxes, of other arguments, of other figures that are really good. They're peer-reviewed. They really were part of the body of work. They just didn't fit in the journal. So, for example, there's a box on antimicrobial resistance, using artificial intelligence as a way to drive that, more work on pandemics and other activities. And so, that should be seen as part of this report. Globally, there's no question now that NCDs are replacing communicable diseases as a cause of mortality. You already heard Angela said it, but I'll repeat it. Tobacco control is the most important for the 50 by 50, and this is about the public policies. And I have to say there's a lot of nefarious actions from the tobacco industry pushing back on the public's attempt to do this, but what we need to do is get taxes up. WHO recommends 70%. We need that everywhere. We need track and trace to be able to make sure that there is no fraud in the movement of that. And these tools can be used for other things to help countries with their excise taxes, including fuels, which have contaminants have an effect on air pollution, alcohol, sugared soft drinks, which are not the new tobacco, and of course pharmaceuticals, which we have a real problem in many countries with fraud on. And then finally, the last thing that Angela talked about was focusing the development aid on health, on direct financial support to the countries with the least resources, which is important. That has been going down. It's been going the wrong way in terms of the numbers. And then on this critical issue of financing global public goods, we can't rely on the pharmaceutical sector to make the products we need that are the right ones to use in developing countries. And so we need to make sure that we have those resources from the public sector to give us the tools we want to get to 50 by 50, but of course, continuing this amazing progress in global health. Thank you.
Thank you, Seth. Fantastic. Look back and look forward. Now, please welcome the former Prime Minister of New Zealand, Helen Clark, who is going to give her reflections on these commissions on investing in health. Helen has many roles in global health today. Perhaps her principal one right now is being chair of the board of PMNCH.
Thank you, Richard, and good afternoon, everybody. Well, I like the report. There's an awful lot to digest in it, and obviously with the PMNCH hat on, we're just absolutely delighted at the extent to which the maternal newborn child health issues feature in it. But let me say there's other aspects of the report I find extremely appealing as well. Obviously the focus on tobacco, which is, as Angela said, one of the leading causes of preventable death in many places. Fighting tobacco is an issue I cut my teeth on as a Minister of Health in 1989, and in 1990 introduced what was then the world's most comprehensive smoke-free legislation. So I know what it's like to take these companies on, but we have to do it. And the work that Larry Summers and Michael Bloomberg have led on fiscal incentives for good health policy reminds us time and time again that these, quote, sin taxes, tobacco, alcohol, sugar, etc., they really are important. They do generate revenue, but wouldn't we be happy if they never generated any revenue because they'd succeeded in reducing to the negligible point the consumption of these products? I'm very happy the report focuses on this. Also very happy that it keeps the focus on pandemics, because we're so far into the cycle of panic and neglect that the ongoing threat of pandemics may not be top of mind of every leader in the world at the moment. But people should wake up at that figure, Angela repeated again, of a 23% probability of a pandemic killing at least as many people as COVID did in, the next 10 years. I mean, that should focus minds about the importance of that agenda. And then we're also reminded in the report about the critical role of public finance. And I'll sort of perhaps comment briefly on that in two respects. One is still the traditional donors have a role to play in solidarity funding for low-income countries and support for the priority health interventions. And secondly, the issue of global public finance for global common goods like pandemic preparedness and response. And we're not, I think, seeing innovative enough thinking yet around that, but I personally am rather attracted to the global public investment concept, whereby every country pays in according to its means and you allocate according to the need. And there is a case, I think, for setting up all new funds on that basis, and maybe even converting existing ones, because the replenishments are getting harder and harder in the world that we live in, where there are so many pressures on the development dollar. The progressive universalism concept, I think, is good. You can't do everything all at once, and the reality is that even those of us fortunate to live in countries which have long had universal health systems, we know that we didn't start with everything at the beginning either. We built on it, and we still build on it in the way that we add to what we can offer. So I think the report is so important in prioritising, in saying if you do these things, you could expect to get these results. And Angela talked about being a pessimist or a sometimes optimist. I'm often a worried optimist, a term I got from Jan Eliasson, the former Deputy Secretary General of the UN. But the case for being optimistic about this focus and prioritisation working is that the report shows us that since 1970, 37 countries have halved premature death in 31 years or fewer. So it has been done. Now, let's acknowledge, as Richard emphasised again, we're not in the best of times, we're virtually in the worst of times, but nonetheless, the track record is that if you do prioritise, you can get results like this. Now, perhaps just a couple of comments, Richard, specifically on the PMNCH issues, and as I say, we're so happy that they feature in the report. PMNCH was engaged in the discussion and development of the report, and we think it's going to be so helpful for advocacy and for seeking accountability. 8 out of the 15 priority conditions are across maternal, newborn, child and infectious diseases conditions. And in addition to driving down mortality, interventions in these areas would also reduce morbidity and loss of function and lead to overall improvements in welfare and economic growth. It goes without saying that just 6 years out from 2030, the target date for the SDGs, we're obviously not on track to achieve the targets in the maternal, newborn and child mortality areas. And to do so, we would need to accelerate progress 9-fold to get to the maternal mortality target, 3-fold for stillbirths, 4-fold for newborn mortality, and 4-fold for children aged 1 to 59 months. I mean, it's a steep hill to climb. So prioritisation becomes extremely important. But I'm convinced that with focus, one can achieve a great deal. Where I think the report will be very useful is as member states look to how they will implement the very important resolution from the World Health Assembly this year, which Somalia was such a leader on, accelerating progress towards reducing maternal, newborn and child mortality. And that calls on member states to scale up cost-effective interventions in newborn, maternal and child health services, including routine immunisation and family planning. So the findings of the report, I think, can start to inform how countries roll out and implement that resolution. But to bring my comments to a conclusion, PMNCH is a large partnership, somewhere around 1,500 partners now, and we will certainly be taking the report as an advocacy tool about how to focus, prioritise, make progress, and reach important targets. Thank you.
Thank you so much, Helen. Very wise words from you. I'd now like to invite Olive Chan to come to the stage. Olive, advisor to Prime Minister Cyril Ramaphosa on social policy. And Olive is going to give us her reflections, I think, on the universal health coverage dimensions of the Commission.
Okay, well, good afternoon. This is almost the end of the summit, a brilliant summit that we've had, so that's really great. I'm going to focus on the question of universal health coverage and comment a little bit about some of the areas that I think need to be focused on. The Commission itself, I think it has had really bold recommendations. And the recommendations that were made, I think they could truly shift the needle and reduce premature mortality by 2050. I think the report is clear. If countries prioritize addressing those 15 health conditions, which my colleagues have said here, we can cut the probability of dying before age 70 by 2050 if we use 2019 as the baseline. And the evidence is actually encouraging because if you look at countries like Bangladesh, Ethiopia, Turkey, Iran, they are already on track by following this particular approach. The report itself emphasizes that UHC health benefit package that targets these 15 key conditions can help indeed to reach the 50 by 50 goal that Angela so clearly indicated, particularly if we strengthen the primary healthcare systems. Now, I know many of you are going to start thinking about vertical versus horizontal programming. But if you look at it very closely, you'll come to a different conclusion, that it's not so simple. What the authors are basically suggesting is that we start with these 15 priorities and gradually expand them to cover the entire health benefit package. And what I like about it is that it's actually evidence-based. You know, they have really relied on research to be able to come to those conclusions, which I think is good. But there are challenges in achieving UHC. And one of those major hurdles is that if you address these 15 health conditions effectively, you need to ensure that you can do cost-effective analysis But you can't do cost-effective analysis unless you have health economists. And all of us who come in from the Global South know the challenges of attracting health economists to come and work in the public sector. They often work in the private sector, or they are having their own companies where they do consultancies. And it's extremely expensive to get health economists. So I do suggest that the better thing to do is really to prioritize training health economists in the Global South. And I think it will be a game changer, because you can't talk about cost effectiveness without having someone to build a case for that. But another comforting aspect of the report to me is the recommendation that countries earmark additional funding, that's about 1 to 2% of the GDP, for the 15 priority conditions. To me, it's exciting when you say that, because it means that you can focus on those interventions without necessarily neglecting other issues, because you're looking for additional resources to do that. Now, on resource management, which is very key for universal health coverage, the commissions recommend for better resource management that we really have to improve the way in which we plan and the way in which we implement, so that the funds that are allocated for health should never have to be sent back to national treasuries. Because that amount of money that is turned back to national treasuries, it's really money that could have been used for primary health care. It's a lot of money that governments are not spending. Now, I think we could move the needle significantly, on achieving UHC if we adopted what they say a one plan, one budget, one report approach. To me, I think it's a very, very important way to achieve universal health coverage. If you just look at the Eswatini example, they were one of the countries that had the highest increase in HIV globally, and that was around 2010. They used this particular approach. They centralized their resources into a unified plan and a budget, and they managed to achieve one of the highest decreases in HIV incidence worldwide by 2020. In fact, they had like the top 5 in the world, from being almost the last to being almost the top. Now, I want to talk about the issues of inequalities, because UHC is something that is supposed to reach everyone, but it depends on when you want to reach everyone. Sometimes the limited resources and their poor allocation prevents UHC from being realized. Some countries attempt to introduce social health insurance, but it can deepen inequalities. And I'm talking about social health insurance versus comprehensive universal health care. If you look at the private insurers, they often focus on state employees because the state puts its money to the private sector. And what happens is that the people that are actually contributing to the state are the ones who are the last to get good health care. The best health care is obtained by people that are working, who are earning money, because the state tends to put that money for them to get health care. What is of concern to me is that this social health insurance often excludes older children, it excludes elderly people, it excludes even some of the members of the family who live with the person who is actually employed. That is a concern. But government can help to improve this situation if they were to pool all of those resources in line with the plan that the report suggests of one plan, one budget, and one report. Next, I want to talk about the issue of balancing supply and demand in health services. So another challenge with focusing on the 15 key health conditions is that it tends to emphasize too much on the supply of health services, but sometimes overlook the demand side. Several studies have shown that even when the health services are available, people may not use them. If you look at systematic reviews that were done in the UK, you'll find that people with mental health seldom use the services even though the state has made them available. And the reason for that is because of stigma and discrimination. We've seen the same thing with regard to vaccines. Some of the people could not use vaccines because they had no trust in the vaccines that were made available. On healthcare financing and equity, I just want to say the Commission's argument that increased private spending could put more pressure on public finances resonates with me. Instead, they are proposing that there should be a mandatory user taxation, which is more sustainable. My own country, South Africa, has just passed a law, which the President has signed into a law now, of National Health Insurance Act. To me, it's a great example of how a combination of taxes can actually make UHC affordable. The government would make the revenue available, the bulk of it would be government payment, and then employers and employees would contribute on the gap, and there will also be a surcharge. Now, this approach of innovative financing makes UHC more affordable. It means that we are not going to be asking for too much money from international sources because we're going to tax our own people to pay for their own health care. I'm almost done, but I wanted to talk about how we can overcome some of the barriers, to UHC. The Commission recommends that countries should increase domestic funding while ensuring equity in coverage. And I've heard about this progressive universalism, which I really, really like. I think it's a great, concept, and I think it is the right approach, which we must be supporting. Our country, South Africa, started with a stepwise approach, which I consider that to be a very good example. When President Mandela came into office, he said, within the first 100 days, I'm going to make free health care for pregnant women, lactating women, and children under 6 years of age. Within 100 days, he did it. It was available. But of course, there were gaps. And I remember when I started my job in government, I started in the field, trying to find out whether there are clinics, whether there are doctors, whether there's medicine, and all of that. 2 years later, I was fortunate to be a Director General of Health under the Mandela administration. And what we had to do was to immediately expand universal primary health care. And now the government is moving towards a comprehensive national health insurance with hospital services in both the public and private. So that is really great. Lastly, we must recognize the real challenges with regard to UHC. UHC faces many, many challenges. There are vested interests that we're dealing with, particularly the private sector. They want to maintain the status quo, favoring the wealthy. So I support the Commission's concern that the growth of private sector health spending will put pressure on public sector spending. By introducing social health insurance for state employees, the state is putting money in the hands of the private sector. Consequently, countries like mine, South Africa, spend disproportionate amounts of their GDP on the private patients. If I give you the example of South Africa, 4.5% of the GDP serves 15% of the population, leaving the public sector underfunded, with 3.7% of the GDP serves 85% of the population. That is government giving money to the private sector, to people that are wealthy. We need to push forward. Publicly funded UHC with no out-of-pocket service cost is the way to go, as far as I'm concerned. In summary, the report says that if we decide to intervene by addressing these 15 health conditions, we are likely to be on the right track to implement UHC and reduce premature mortality by 2050. It's all about prioritizing efforts to address those 15 health conditions, strengthening primary health care, allocating resources efficiently with cost effectiveness in mind, ensuring equity in implementation, and making smart fiscal choices to favor public financing for health. Thank you very much.
Thank you very much, Olive, for that reality check about how one translates a 50-plus page report into practice and policy. I hope we can have a little bit more discussion about that when we come to the Q&A. It's a great pleasure for me to introduce our final speaker this afternoon, Leah Tades, who is a former Minister of Health of Ethiopia and is now Executive Director of the Harvard Ministerial Leadership Program. And Leah is going to talk a little bit about the financing dimension, the arrow mechanism in the report. Please welcome Leah.
Thank you so much, and it's hard to follow all the great speakers at the end. But first, let me really share my excitement about this report. One, because it has increased my optimism. I'm an optimist in general. I try to keep challenging my optimism, but it really has increased my optimism because it has shown us that this is, despite all the challenges we are in, of course, with increased commitment and action, that this is possible. But the other reason for my excitement is also the approach it has shown in terms of health system strengthening. The discourse we always have on health system strengthening versus interventions or programs, we all know we continue to have this discourse, and we, of course, especially as countries, we try to ensure that the investments we make really are focusing on health system strengthening, but we know that also the key interventions are critical. So this report has really shown us on unpacking on how to approach health system strengthening in a way that we can focus again the limited resources on priority interventions and ensure that the health systems are strengthened in a way they can fully deliver those services. And this can, with the evidence it has shown that this can result in not only achieving the reduction in the premature mortality, but also in reducing mortality in all ages and achieving resilience and universal health coverage. And I will definitely be focusing more of my reflections on the financing aspect, and to achieve what's outlined in the report, the key component, of course, in addition to political commitment, and as stated in the report, it has to be owned and by countries. But the central point to this is the financing. And when we say financing, the first point is the need for additional financing, of course, and the focus being the need for domestic financing to cover most of the interventions. And when we are talking about domestic increased financing, it is clear that most of our countries at this time are very challenged with inflation, debt servicing, and many crises that are competing priorities. But still, there is a need to continue pushing for increased government allocation for health. And this will, of course, require increased revenue for governments. It may be requiring different interventions like policy reforms in tax, but also other interventions like national health insurance systems that would bring more money, but also what was mentioned through tobacco tax and other unhealthy products being taxed. But we also know that, first of all, increasing financing is not easy, but also increased resources does not necessarily translate in increased outcomes or, for example, reduced out-of-pocket expenditure. So how we invest the resources that are already there or that will be newly mobilized is really critical. And the report has really outlined different interventions that we need to do, and we know it's not only one approach that will result in this. And one key area we always talk about is enhancing public financial management of countries. And this is definitely primarily the responsibility of government to improve public financial management, but also it's also our collective responsibility at the global health community, especially in the way we provide development assistance. The way we provide development assistance has to really complement the efforts of improving public financial management by governments. If, for example, if donors are always channeling all their funds to implementing partners and not to government, this progress will really not be achieved. So there needs that also requires collective commitment. But the other central piece that's highlighted in this report is the issue which is partly for on the efficiency of resources, but also partly on achieving the key outcomes itself, is the issue of commodities. Available quality essential medicines, diagnostics, and supplies in the health system, particularly in the primary healthcare system, but also at all levels of the health system, is a key bottleneck that all of our countries are facing to provide care. In most instances, we know that governments in the past collectively, as with development partners, collectively have been investing a lot on putting the infrastructure in place, training health workers, and maybe having at least some of the needed infrastructure and equipment in place. But sustainably providing the needed commodities, drugs, supplies in facilities has been a critical bottleneck in terms of providing quality care, but also the causing catastrophes in finances for the communities, resulting in huge out-of-pocket expenditures. If you look at the percentage of out-of-pocket expenditure, the largest part, particularly for low-income countries and low- and middle-income countries, is from what they expend to buy drugs and medicines and supplies. And for my country, Ethiopia, we have committed, for example, to provide maternal health services and newborn health services for free as an exempted service. It's not included even in the insurance system. It is subsidized by government, but it has been increasingly difficult because of this lack of commodities, where at the end of the day, even if they don't pay for the services, they would end up paying for the needed supplies. And we've been working on what are innovative ways we can really mitigate this by establishing new health funds and other modalities. So the proposal, the recommendation in this report of particularly the arrow mechanism is what I would like to reflect a little bit on. Of course, again, when we are the report is proposing this arrow mechanism, it's not the only way that we're going to alleviate the challenge of commodities. We need to be working in different areas like enhancing local manufacturing, improving regulatory capacity, and improving supply chain management. But this intervention also really brings light important interventions. And this is not an entirely new thing. It has been, this approach has been tried through the Global Fund to avail malaria medicines. And also some component of it is also being used in different countries. And the first component, as presented earlier by Angela, the first component in this approach is the redirection of budget, of general budget transfer to ministries of health, specifically for drugs in a line item budget for those priority interventions. And when we hear this, I'm sure there is, of course, line budget item is not a new thing. We use it in many of our countries, but restricted or earmarked budgeting is not something we really like in many governments. And being a former minister, I know that. Because we prefer flexible fundings. But the idea here is not, first, it's not meant for all the interventions we need to move to line budget or earmarking. It's talking about the priority interventions and also the drugs, the commodities that are needed to really address this. And some of the diseases like in the priority, like the HIV, tuberculosis, fortunately, are still being covered by the Global Fund and other mechanisms. But there are so many interventions that are no way that the governments are able to cover or are funded by different mechanisms. So having a clear earmarked budget for this with government allocation, but also supported by development assistance with a pooled approach, but earmarked in those areas, especially for issues like NCDs, maternal, newborn issues, others that are still underfunded like nutrition. So these are priority interventions based on country context that we need to put earmarked budget that we agreed upon. And this protects also that budget for the ministries themselves. Once we have a budget, even with the ministries, there are competing priorities that pull us apart. But if we have this budget allocated for those priority commodities, it ensures the availability of these medicines. And we have actually an experience for Ethiopia where there was a decision made for family planning commodities because it was a critical challenge, but to have a line budget item. The second component, it's not enough to have that budget. And of course, we are hoping that there will be more resources coming to it. But it's how do we procure these medicines? And pooled procurement is a key approach that's proposed as part of this ARO mechanism. And pooled procurement is very important for many reasons. One is it brings economy of scale. For Ethiopia, we have a national procurement agency under the ministry which does large of the procurements for the country with all its challenges, but it has definitely shown the economy of scale of the limited resources we have. And also, it's not just having the pool procurement, but the proposal clearly outlines having long-term commitment with either the suppliers or manufacturers in terms of the procurement. And this is also something I can relate to very well, because for our procurement agency, we were procuring every 1 year, but the procurement process itself takes maybe 3-4 months, even more sometimes. And then within few months, we are again starting another procurement cycle, creating gaps in availability. So a few years back, we started what we called framework agreement, where we have 3-year agreement with suppliers, which ensured sustainability and gave us time to do other procurement cycles. And doing this also, the other component that is outlined here is doing this in addition to just having procurement, but we have to do this through existing supply chain mechanisms, preferably that are already available through government, which also enables us to strengthen the supply chain management, but also ensures that we don't have any other duplicated efforts. But of course, in cases where that does not exist, using other existing mechanism of private sector or UN systems may be important. But also the importance of really, when we are doing this pool procurement, the importance of procuring enough quantities is also really highlighted. And this requires, again, supporting the forecasting capacity of countries to ensure that the right amount of supplies are being procured for those services. So again, this is not the only thing that countries should do, but this is something that we can look at and based on the country's context utilize. But the central point is that availing essential quality medicines and supplies for priority interventions is really central to achieve this ambitious goal of reducing mortality, but also achieving universal health coverage. And these innovations would be really important. Thank you so much.
Thank you so much, Leah. Fantastic. Right, we've got limited time for questions, so we're going to be super quick, and we need super precise answers. Those of you who were here for the morning plenary will have seen Alan Dangour from Wellcome Trust say that if his job as a funder was simply to have science done and papers published, then his job would be complete. But of course it's not. He wants to engage with the policy process. And we say something similar at the Lancet. We talk about the afterlife of the Commission. Publication is the beginning, not the end. So the question I want each of our panelists to answer is this. What immediate actions would you like policymakers, decision makers in governments to undertake to realise the tremendous opportunity that the Commission sets out? So let's go down the line as we started. And Angela, immediate actions.
Okay, I'll keep it short. You've heard multiple times we say the word focus. I think focus, focus, focus. Yesterday, Bill Gates, during the investment round, also mentioned the need for global health to focus in this era. So we talked about some of the priorities and what we say. And I think Larry Summers, our co-chair, has also told us as commissioners to also focus in what we say and what we don't say. So prioritize what is important, but equally importantly is to deprioritize the things that are not important and be conscious about the prioritization and deprioritization of what you do.
Thank you, Angela. Seth.
I mean, the challenge, we live in a reality of politics, and I think that is the challenge, because I agree 1,000% with what Angela is saying. And so the challenge is convincing people that despite the politics, one needs to focus in. And a number of the points that came out in the Commission, tobacco is the new tobacco, I mean, every country should do that. And right now, I mean, even the countries who have signed the framework agreement on tobacco haven't necessarily moved forward. So what we want to see is these specifically move. Now, two other things I'll mention is, on the pandemic side, I mean, we're back in a neglect phase, and I'm not sure how far we're going to move, and yet I think we're seeing the difference that the climate and the environment is making. We're seeing more frequent outbreaks. We're seeing severe diseases move back into their ecological niches, so we need to really be focused on that. And then lastly, I think, and Olive, talked about this as well, is this idea of, progressive universalism. Yes, we need to have comprehensive health care, but if we try to do everything, we do nothing. And I think this is the experience, and so really having a mechanism for countries to focus down on some priorities to do that is going to be really important.
Thanks, Seth. Helen.
Well, I think that the report is important for the donor community too, because health's been a bit off the boil in development funding, and for the donors who tend to be very results-oriented these days, the thought that if you back these horses, you'd get results. I think that has some appeal. So I think there's quite a powerful message in this. There, Olive and I were talking not long before we came on stage also about domestic financing and countries, prioritising their own public spending around health as an investment, not just another bit of social spending, but if you're not investing in the health of your people, you're limiting your potential. So I think it's a very powerful advocacy tool, but it's also a guide as to the steps you could take to make a difference.
Thank you, Helen. Olive.
In terms of donor community taking it, from where you left off, I think organizations such as Gates Foundation can actually go and start a program to train health economists, because I think they're going to be very critical to get the job done. WHO can, with the resources that were pledged, they can go ahead and start strengthening their technical support to countries to make sure that they can focus on those 15 priority areas so that they are appropriate for their own countries. And Gavi, I think they can start procuring vaccines from low and middle income countries to encourage them so that they can set up their local manufacturing ahead of the new pandemic that might be coming. They need to focus on that. Thank you.
Thanks, Olive. Leah.
Thank you. Well, my first ask would be for all countries, especially ministers and their teams, to read the report. And also the partners, donors who are also in country to read the report, because I think understanding the in depth that would really be important. And then I think it's really to look at an honest look of where we are in our strategies and examine, based on the report, doing analysis of our priorities to really move forward. So that's my ask. Thank you.
Thank you. Yes, Seth, come back.
Sorry, I forgot to say one thing, which is let's not forget the revolution. I didn't say it in my remarks either. In the vaccine space, there's a renaissance of new science coming down and vaccines against important diseases. It's true in drugs. It's true in many aspects of what's happening here. And again, we need to make sure that donors understand that and focus not just on the important delivery, but also making sure that these new tools are made available and accelerate along. And I think we have to make sure that everybody's thinking about that.
Thanks, Seth. At the session we had just before this one, where we had a slightly deeper dive into the detail of the commission, we learned that there's going to be a national commission set up in Nepal. And I wondered what the opportunity was for national commissions. I remember with Global Health 2035, one of the post-publication processes was working with countries to see how the ideas in that commission could be realized into policy. Could we talk a little bit about the opportunities for national commissions?
Yes. So we currently have 3 country-specific commissions that are in planning. And the direction really depends on the country partners, not on us. So we are supporting roles to these countries. So one is Nepal, led by Professor Shiva, who is here. He is the vice chair of the Planning Commission in Nepal, and we will be working closely with him and the team. The second is in Nigeria with country partners. And the third one that Larry Summers in particular is very excited about is a commission on the US. Yes. And trying to understand, coming from a very different perspective from domestic researchers in the US, what does the Lancet Commission think about the US current state? In addition, we have been working with expert groups in both Norway and in Denmark in trying to inform their policies around their ODA in the coming decades.
Thank you. I just wondered, Helen, Olive and Leah, the idea of national commissions in your 3 countries, do you think that's something that's worth exploring as a commission?
Yeah, I do think that it would be important for South Africa if you can introduce that, because we've been participating in some of these commissions when they took place. So, yeah, I think it's something that we should explore.
Okay, we maybe follow up on that, Leah.
We actually had the experience for a local Lancet Commission for NCDs before, which had really a great input in how we approach NCDs, the decentralization, and the work we did. The only concern I would have is sometimes it takes a longer time when we are having the commissions in terms of translating it into action. So, but it is really helpful.
Okay, very good. Helen, do you think, because this is a commission for all countries?
Yeah, and I mean one of the insights from the Sustainable Development Goal period was that everybody's got to do stuff, right? Yeah. And whether the problem may differ from region to region, but high-income countries have got plenty of preventable deaths from the NCDs, and again, I emphasise the importance of tackling the tobacco problem. So yeah, there's no reason why high-income countries shouldn't be taking this report very seriously and looking at how they can adapt its findings to their context.
Our time's almost running out, and I'm going to hand over to Dean Jameson, who is our spiritual as well as intellectual leader in this. In a moment. But I want to just give the panelists one last chance. Send this audience home with your final inspiring thoughts about what the Commission is encouraging us to do for the future. We want to end on a note of optimism, so I'm going to start at the other end this time. Leah, take it away.
I think the main message was already said is focus, prioritize. And with that, because we have limited resources, whether we like it or not, but with that, we can achieve our ambitious goal.
Very good. Olive.
I think it's going to be very important that the Commission, realizing that we're not going to meet the Sustainable Development Goals, to push even harder for universal health coverage. I think they should spend a lot of time to do so.
Yeah.
Secondly, they must realize also the consequences of this particular report, in the sense that people are going to live longer. And if they do live longer, it means that we must have elderly-friendly services. They must be available, and there must also be long-term care, for those. And finally, ensure chronic disease management is actually addressed. Thank you.
Thank you, Olive. Helen.
I think the report could be a guide to how we try to step up progress in the last 5 years of the SDGs. We've got all these failing targets. About, 14% of the targets are on track. Health targets are off track. So it could be a guide to focused and accelerated action in the last 5 years through to 2030.
Seth.
One other country that's already talking a little bit about this is Mexico, and I think we'll see other countries. But for me, I think the really critical issue is keep the buzz going, because there's a danger. Next week, there'll be another issue of the Lancet, and there'll be another commission, and there'll be another this. And the experience we had in the past with some of the other work has been that if you get regional conversations, it doesn't have to be every single country, because that's hard, but regional conversations, sharing of information, and the experience of somebody making progress on it inspires others. So keep the conversation going.
We'll keep the buzz going, absolutely. Angela.
I'm thinking about other sectors in mind. In Denmark, for example, there's a concern that health is falling off the development agenda. Right. And so in thinking about other sectors, I would say, keep health as a focus, key focus in the post-2030 agenda, or whatever agenda that we have in the future. Keep health as a focus, because it's consistently been a good performer. As Gates said, there's high return on investment, and it's fairly certain compared to the other sectors. So I would say keep health as a focus. And it's my personal view, I think health is a multiplier of other things that are happening in the world. And if we can get health right, and it will be easier, relatively easier for other sectors to perform.
Thank you, Angela. Please give the panel a round of applause and welcome Professor Dean Jameson.
Well, good afternoon, and thanks, Richard, and thanks for a wonderful panel. I continually, after several years of working on this effort, surprised at how much I learn with every new occasion still, and I've learned a lot. I'd like to turn, as Seth did, just a little bit to aspects of the history of this work, going back to WDR 1993 from the World Bank, and the what I think of as two overarching intellectual positions that have guided the work through these commissions and from the WDR 93. One of those is that, in contrast to earlier history, by earlier a couple of hundred years ago, this century and the 20th century have had a harvest of scientific knowledge translated into products and algorithms and scientifically based public policies that have enabled an enormous improvement in human health, more or less, and this is the second major contribution of science, more or less independently of the income level of countries. Not completely independently by any means, but the advances tend to enable huge advances in health at modest cost. So science-driven potential, and as we've heard last night, today, that's a potential that is growing. We have more options. So that's one strong intellectual base for the work we've been doing. The second grows out of a reaction to the Washington Consensus. And the Washington Consensus, as I think most of you know, the name Washington comes from three institutions within a few blocks of each other in Washington, D.C., the IMF, the World Bank, and the U.S. Treasury. And the views in the early 1990s, and that have continued for a long time since, emerging from a Washington Consensus, was to limit the role of government, limit government expenditures, limit the action of government in regulating and restricting private economic activity, let a private economy driven by private demand grow. The chief economist of the World Bank at the time, Larry Summers, who's been mentioned a number of times here, was one of the architects of the Washington Consensus. And as chief economist of the bank, one of his roles was to decide each year on what the next World Development Report's topic would be. And there had been two World Bank reports in the early 90s, one on stimulation of economic growth and the other on reduction of poverty, that had as their main intellectual directions a Washington Consensus limited government approach. And Larry's, and I'm not much of a Washington Consensus person, to put it mildly, but I think those were actually pretty good and thoughtful reports. Larry's take at the time was that things had gone too far in those reports and gone too far in the general development discussion in this limited government perspective. So he chose a sequence of 3 topics for World Development Reports where he explicitly expected the conclusions to be that a much more substantial role for government was absolutely essential to progress. The first of those reports was on the environment. So 1992, a strong concern on environmental action and the necessity of strong government action in achieving environmental goals. The second was 1993 on health, and the third was 1994 on physical infrastructure. So that was a dual context, this Washington Consensus in a reaction against the Washington Consensus, not against the Washington Consensus, but a sense of the incompleteness of the Washington Consensus as we think about development at all income levels. So those were the 2 guiding frameworks, and we've heard from every panelist today about the essential role of public sector finance, phrased in slightly different ways. And it has been the importance of public finance to achieve these goals. If we speak of countries being able to choose 50 by 50, we mean by that governments can choose to allocate their budgets to achieve 50 by 50. It's not a more general concept. The role of government and government finance is absolutely essential. I take a final message away from Larry Summers. He's been a big influence on my life. He is, for those of you who know him, can be abrasive and is always impatient. And the constant harassment from above, if you wish, about let's get this thing done. Let's get going, and then let's get this done. That's not my temperament, but I can be pushed. But that would be the final message that I would leave today, and that is a sense of urgency, a sense that we really have to get going quickly on the kinds of agenda items we've been discussing, and with a strong attention to first things first, but an urgency of moving forward in each of the roles that we individually play, moving forward quickly now. Thank you.
Thank you very much, Dean. And to close the summit, please welcome President of the World Health Summit, Professor Axel Priest.
Thank you very much, Richard. Thank you all in the panel. With this brilliant insights of the panel, the World Health Summit 2024 comes to a close. Every good thing has to come to a close. I thank all people who contributed, the people here in the hall, the people in all the sessions on the panels, but also I would love you to give a big hand to our staff in all functions, from security to background. I hope you enjoyed it. We take every comment very seriously. If anything was not good, let us know. We will try to improve, but I think quite a few things were good. And not only this panel, but also some other things. Even the weather now is good. So I wish you a very safe travel home. Come back next year, enjoy, stay healthy, and be the global health community who, despite all the things in the world, hold stuff together. Thank you very much.
Well done. Well done. Well done. Good job. Fantastic.